Hi, and welcome to the second part of this introductory lecture on substance use disorder. Again, my name is Dr. David Eddy. I'm a clinical psychologist at Massachusetts General Hospital and Harvard Medical School. So today I'm going to be first talking about how we diagnose substance use disorder. What are the diagnostic criteria we use? How do we classify substance use disorder in terms of severity? And I'm going to spend a little time talking about stigma. Substance use disorder is among the most stigmatized conditions, and stigma can really impact whether people access treatment, their experience in treatment, and their recovery. So we'll spend a little time talking about stigma. And then I'm going to talk about treatment. What are the first line and second line treatments for substance use disorder? And also, what can we anticipate or expect in terms of recovery? All right, so let's talk about diagnosing substance use disorder first. So you will see here on the left-hand side diagnostic criteria that have been used either in DSM-4 or DSM-5 to diagnose substance use disorder. Now, just to back up, DSM stands for the Diagnostic and Statistical Manual of Mental Disorders, as produced by the American Psychiatric Association. It's really the diagnostic compendium that we commonly use in the United States, although there are other ones like the ICD-10, for instance. So DSM-4 was phased out in 2013 when DSM-5 came along. You will see there were some pretty significant changes from DSM-4 to DSM-5 in terms of how we diagnose substance use disorder. But first up, let's just have a look at our diagnostic criteria here on the left. You will notice all these diagnostic criteria map onto the sequelae or the consequences of problematic or excessive substance use. None of them map onto excessive substance use itself. Or maybe one of them, loss of control, in a way does. But when we're diagnosing substance use disorder, we're actually not so much interested in how much or how frequently people are using alcohol and other drugs. We're more interested in the consequences they're experiencing. You might think, well, that's a bit odd. It doesn't really make sense at all. Of course, it's important how much and how frequently people are consuming alcohol and other drugs. Well, it is. It is, of course, it is. And at the same time, there's tremendous variability in the terms of how much alcohol and other drugs people consume. And some people, for instance, with alcohol, consume alcohol in fairly large quantities, but they never have the problems we associate with substance use disorder or alcohol use disorder. So we might say that somebody drinks in a way that's unhealthy, that could produce problems for them later on, medical problems, for instance. But we might not necessarily say they have an alcohol use disorder unless they meet these diagnostic criteria. So let's talk a little bit about the diagnostic classification. So in DSM-4, we had two different categories, abuse and dependence. There were separate diagnoses. So to meet diagnostic criteria for alcohol abuse, you had to one or more of the following four criteria. And you see the first four here. I won't read them off, but the first four criteria map on to the abuse diagnosis. Then we have 7 other diagnostic features that mapped onto the dependence diagnosis. Now, to get a diagnosis of the alcohol or other drug dependence, you needed 3 or more of these 7 criteria. Now, there were some problems with this diagnostic framework, and that's why we changed in DSM-5. First up, we don't really talk about people as abusing substances anymore because it's really, really stigmatizing, and I'm going to talk about that shortly. So that's one of the reasons. Another reason is it was felt, and many still believe now, that our bar for diagnosing a substance use disorder is just too low, so that we would catch, especially with the DSM-4 criteria of abuse and dependence, we would end up catching a lot of people who would meet criteria for alcohol or drug abuse, but they might not necessarily actually have a problem. Like anybody who's using alcohol or other drugs excessively might meet the abuse criteria. So many people felt that it was just too loose, that the criteria were just capturing too many people. Didn't necessarily represent a problem. And the other problem was that we would have what we would call diagnostic orphans. So you would have individuals who didn't meet any of the abuse criteria, but they did meet two of the dependence criteria. So by the letter of the law, so to speak, those folks with two dependence criteria, no abuse criteria, would not receive a diagnosis because they don't have three or more of the dependence criteria. They don't have any of the abuse criteria. So they wouldn't have a diagnosis, even though you would say qualitatively they're using substances in a more problematic way, or they're experiencing more problems as a result of their substance use than somebody who would say, be experiencing recurrent substance use resulting in failure to fulfill major role obligations, who would get an abuse diagnosis. So that was another problem. So in DSM-5, they got a work group together, a group of experts, and they solicited feedback from the substance use disorder research community and the clinical community and the general public as well. And they made some pretty big changes. The biggest change was that they got rid of the abuse and dependence criteria, just went to one diagnosis, substance use disorder. And what they said is you can either mild, moderate, or severe substance use disorder. Mild, if you had 2 to 3 of these criteria, moderate if you had 4 to 5, and severe if you had 6 or more. Now you'll notice a few other changes. There's 2 other changes in terms of the diagnostic features. So they got rid of recurrent substance-related legal problems. You can perhaps guess why. Problem was, the people who have recurrent substance-related legal problems were often not the people who were using alcohol and other drugs in the most hazardous way, or often the most marginalized people. These were people identifying as racial minorities, people of lower socioeconomic status, were much more likely to experience legal problems as a result of their substance use than their more affluent or white peers. So there were clear problems with that diagnostic feature, so they got rid of it. And the other thing is they added a feature in DSM-5, and that was craving. Now you might say, well, it's a bit strange that that was not in DSM-4, given that seems to be a cardinal feature of addiction. Actually, the data on that are a little mixed, but it was agreed. Craving is important. It should be in there. So they added that to DSM-5. Okay. Now, interestingly, once you have a diagnosis of substance use disorder, you never lose it. You keep it, you retain it for life. Now, of course, you need to have some kind of modifier so that you can code diagnostically somebody's recovery from substance use disorder. So if somebody has received an SUD diagnosis, but it's been at least 3 months, but less than 12 months since they've met diagnostic criteria for substance use disorder, i.e. experiencing that list of problems, you would say they're in early remission. Now, important to note here, this does not relate to substance abstinence or quantity of substance used. It's just that an individual no longer meets diagnostic criteria. They may have continued some form of substance use. More often than not, folks are abstinent, or they've at least reduced their intake of alcohol and other drugs. But abstinence is not a requirement to be in early remission. Same with sustained remission. So if somebody has had at least 12 months without meeting diagnostic criteria, then we would say they're in sustained remission. And also we modify our diagnosis if somebody was in a controlled environment. So you can imagine if somebody was in a residential treatment facility, they might have 3+ months of remission. They could be in early remission, but we put in the modifier there that they were in a controlled environment, because obviously that's going to influence their substance use and their substance use related problems. And also we would put in a modifier if somebody was on maintenance therapy. And now we're specifically talking about medications for opioid use disorder like buprenorphine or methadone. Okay, so let's talk about stigma now. So alcohol use disorder and drug addiction, drug use disorder, collectively substance use disorders, are among the most stigmatized conditions. This is a study, it's a little old now, but it's from 2005. And what the author did was survey people in a bunch of different countries, which you can see along the top here. And they asked them to rank the social desirability of individuals with a range of different problems. And 1 is least stigmatized and 18 is most stigmatized. And you can see the drug addiction and alcoholism, as they refer to it here. We don't use that anymore, but that's the language we were using in 2005. Both really, the drug addiction is number 1 and alcohol use disorder is number 4. So highly stigmatized conditions. And why does this matter? Well, it matters a lot because it really influences whether people engage with treatment, their experience once they do engage with treatment, and can also influence recovery outcomes. And part of the problem is the language we use to describe addiction really comes from the 20th century. And it comes from a time before the American disease model where we really thought about addiction as a moral problem. If you had an addiction, you were just a morally corrupt person. There was something wrong with you. You had poor willpower. You made bad decisions. You deserve what you got. There was an element of blame associated with having addiction. And all those things are still true to a degree today. We've come a long way, and the American disease model helps us think differently about addiction as a condition, a bona fide condition that people have. But the language that arose before the American disease model, and even really through the 20th century, after the American disease model came to the fore, we still used a lot of really stigmatizing language. It's really perpetuated the problem of stigma because obviously the way we talk about things, the language we use to describe things affects how we think about things. There's massive literature and psychology on that topic. So historically, we've called people addicts, alcoholics. We've referred to toxicology results as dirty and clean. So a positive toxicology result is often referred to in the treatment community as dirty. If it's negative, it's referred to as clean. And probably worst of all, we've talked about substance abuse and substance abusers. Well, what are the problems with these terms? What comes to mind when you think of an addict or an alcoholic? Like for me, the image that comes to my mind was one that I'm sure I adopted when I was a child of an addict, is somebody in the street, in the gutter, passed out, maybe, needle marks on their arm. When I think of an alcoholic, the image that comes to my mind is an older man in a raincoat under a bridge drinking a bottle from a brown paper bag. And of course, neither of these images accurately capture the breadth of people with addiction. The reality is people with addiction are our friends and family members. They are often employed. They are often, more often than not, housed. And so, yes, there are very extreme examples of addiction that are often connoted when we think about these sort of stereotypical terms or images, but they don't accurately portray the breadth of people who experience addiction. And that's problematic because then we're pigeonholing people. We don't talk about toxicology results as dirty and clean anymore. At least we shouldn't be. When we talk about dirty results, we set up an implicit association that people with addiction are dirty. That's problematic as well. And what do you think about when you think about abuse? The first things that come to mind for me are sexual abuse, physical abuse, and emotional abuse. Now, to say somebody abuses a drug, well, it's really an absurd proposition. The reality is most people with an addiction, with substance use disorder, have lost the ability to control their substance use. It's one of the cardinal features, the diagnostic features of substance use disorder. Most of my patients desperately want to stop, but find they can't. And so to say that they're abusing alcohol and other drugs, there's an inference in there, like a willful maliciousness, right? That these are bad people making bad decisions, doing bad things. Right? The reality is, as I said, most people with an addiction have lost the ability to choose whether they use or not. They desperately do not want to use alcohol and other drugs, but find themselves compelled to do so. So instead, we want to use more diagnostically specific terms. So somebody with a substance use disorder rather than a substance abuser. We also want to use person-centric language. And this is something we've been talking about in the mental health space for years. We don't call people schizophrenics anymore. We don't call people addicts. Somebody has schizophrenia. Somebody has a substance use disorder. People are much more than their condition. A person with schizophrenia is not schizophrenia. A person with addiction is not just addiction. They're a person with a condition. So we always want to be using person-centric language. And of course, toxicology tests are positive or negative. We want to be using medically accurate, precise, unloaded, unstigmatizing terms where possible. Okay, so let's talk about treatment and recovery. What are our first-line treatments for substance use disorder? Well, I would argue these three, cognitive behavioral therapy, mutual help programs, and medication, are our first line. Now, some others may disagree. Now, cognitive behavioral therapy is a skills-based approach delivered by a therapist with training in this modality. Essentially, the goal in cognitive behavioral therapy is to teach people the skills and tools they need to recover. Generally, in cognitive behavioral therapy, once you've completed a course of treatment, you ideally finish up and move on and continue to use those skills in your daily life. Essentially, in cognitive behavioral therapy, we want people to become their own clinician, to be able to function on their own, to have the skills and tools they need to recover and stay recovered. Mutual help programs, and of these, the most popular or well-known one, the one that's been around the longest, is Alcoholics Anonymous or AA, can also be incredibly effective for the treatment of substance use disorder. Now, there's some debate about mutual help programs and their effectiveness. The reality is there's a fairly sizable literature, at least let's talk about alcohol use disorder, that suggests that mutual help programs are just as effective as cognitive behavioral therapy when people apply themselves, when people get involved. Same with cognitive behavioral therapy, though. If people don't engage in treatment, they don't tend to get this benefit. You've got to do the work in both mutual help programs and cognitive behavioral therapy to derive benefit. In terms of the alcohol use disorder treatment literature, we know that AA does about as well as cognitive behavioral therapy in the first year. And then beyond the first year of recovery, AA actually has a bit of an edge over cognitive behavioral therapy in terms of better outcomes. And that's not too surprising when you think about it, because with cognitive behavioral therapy, folks usually finish treatment and then move on and hopefully apply the skills in their lives, but they're often not getting ongoing support. Whereas with mutual help programs, the model is get better, but hang around and pay it forward, right? And so people who go to AA are more likely to have ongoing psychosocial support. And so that's why we think folks after the first year of recovery tend to do a little better when they're going to AA versus those who had cognitive behavioral therapy. And of course, medications can be really helpful as well. We don't have a ton of great medications for substance use disorder, but for opioid use disorder and alcohol use disorder, we actually have some pretty good medications, particularly for opioid use disorder. For addictions to drugs other than opioids and alcohol, not so much, but there's always work going on in this domain. And there's quite a few medications that are used off-label as well. Then in the second line, we have interventions like mindfulness-based relapse prevention, heart rate variability biofeedback. There's novel mutual health programs like the Phoenix, which is a mutual health program based on exercise and group physical activity. And as well, we have these M-health interventions or mobile health interventions and technology-based interventions, apps and biopatches and so on that are increasingly being integrated into the substance use disorder treatment milieu. Okay. So we have some pretty good treatments. The problem is not many people are accessing them. And there's a range of reasons for that. But looking at the numbers, and these data are from 2016 and they're for the United States, so they're a little old. At the same time, the numbers probably haven't changed much since then. And we can really just speak for the United States with these data, but these data probably generalize pretty well to at least other Western countries. So in 2016, of the approximately 20 million Americans who had a substance use disorder, an active substance use disorder, only about 4 million of them, 1 in 5, received any kind of substance use disorder treatment. This is really problematic. And a lot of researchers have done work to understand why this might be the case. But really, stigma is a big reason. Often people don't want to get substance use disorder treatment because they don't want to be stigmatized. They don't want to be labeled. A lot of people are comfortable with a diagnosis or a label of substance use disorder because they have in their mind an idea of what an addict or an alcoholic is, and they don't want to be that, or they don't feel like they are that. Right? Access to care is also like trying to find well-trained, experienced providers can actually be very, very difficult, even in developed countries. Managed care in the United States has made it really, really hard to access mental health care. Now, the HIPAA Act, Obamacare really did a lot to ameliorate that issue, but it's still really problematic. It's still very hard to access substance use disorder treatment in the United States, even with pretty good health insurance. That said, recovery is possible. Right? So even though most people don't get any kind of formal treatment, most people in the end do eventually achieve substance use disorder or addiction recovery. Now, these results are from a survey we did in 2017 at the Recovery Research Institute at Mass General Hospital. It's a project led by Dr. John Kelly. And what we did is we surveyed, took a random sample of individuals in the United States and asked folks, did you ever used to have a problem with alcohol or other drugs, but no longer do? And we actually started to find out that about 9% of the United States population endorse having resolved a significant alcohol or other drug problem. Now, these folks may or may not have had a substance use disorder. They might not have met the diagnostic bar for an SUD, but these were people who did self-identify as having a significant problem. So that's a pretty big chunk of the United States population. And you think on top of that, about maybe 10%, maybe even a little more of the United States population has a current substance use disorder for alcohol or other drugs. Now we're at about 20% of the population. There's probably even more that are not captured in those two samples affected by substance use disorder. And you think as well about the collateral effects of SUD on friends, family, the economy. This is one of the biggest public health concerns facing America and really probably certainly any Western country and probably many, many countries around the world. Now, it's interesting, if you look at the bottom of this slide here, where we describe recovery pathways that people use, now 54% use some kind of support, but 46% recovered without any help. This is something we call sometimes in the literature naturalistic recovery, natural recovery. These were mostly folks in this sample who had more to mild mild to moderate SUD symptomology. Now, we didn't formally diagnose these people, but we did have measures of substance use disorder severity in our questionnaire battery. And so we know that of those who recovered without help, without formal treatment, without going to mutual help programs, most of those were in the mild and moderate end of the spectrum. Those folks who use support tended to be have more severe SUD-related problems. So how do people who did use some kind of support, some kind of care, how did they recover? What did they use? Well, 30% said they used formal treatment. 9% said they used medication. And these groups are not mutually exclusive. Folks might have identified as, using multiple modalities. 17% use some kind of recovery support service, and this could be like faith-based recovery programs through a Christian church or recovery community centers. And 45% used some kind of mutual help program like AA or NA. And it's probably not too surprising that a lot of people recover through mutual help programs because they're really the most accessible and available, and they're also free to attend. So, we know that the majority of people in America, at least, do find recovery through mutual help programs. And perhaps as more formal treatment opportunities come online, maybe that will shift. But for many, many years, there were very few formal treatment opportunities or options in the United States. If you had a substance use disorder, your best options were AA or NA. Now we have more options, and so you'll probably see that shift a little. But mutual help programs will probably continue to be a very popular pathway for people to achieve recovery. Okay. So now, one last slide. I want to give you a general sense of what to expect in terms of recovery outcomes. What a typical recovery trajectory might look like for somebody. When you hear about recovery success rates, the narrative in society, I think, is that people don't recover from addiction, that they fail treatment, they drop out, they relapse. And usually then, some horrific number is quoted that, only 5% of people post-treatment, achieve sustained remission. The problem is, you take those numbers, they're assuming that folks just make one recovery attempt. And the reality is they don't. Most people require multiple recovery attempts to achieve sustained remission. And the reality is that of people who continue to try and recover, the majority eventually get there. They may not get there in the first try or the second, or perhaps even the fifth. But if they keep trying, they'll get there. So let's look at this timeline. So from addiction onset to help seeking is typically around 4 to 5 years. And within that, often we see self-initiated cessation attempts. So people are trying to stop on their own. Right? Now, addiction onset doesn't necessarily represent the time point where an individual first started using alcohol or other drugs, but that's the time point where somebody had crossed that threshold and met diagnostic criteria for substance use disorder. So about 4 to 5 years before help seeking, of those who reach out for help. As I showed you on a previous slide, many people don't. Then on average, it takes 4 to 5 treatment episodes, formal treatment or mutual help engagement episodes, for people over 8 years on average to achieve 1 year of full sustained substance use disorder remission. Now, these are just averages. Some people get recovery in their first recovery attempt. Some people take many more treatment episodes to achieve 1 year of sustained remission. But this just shows that it takes multiple attempts on average for people to achieve recovery. So we shouldn't be giving up on them because they didn't get well, didn't get better the first time or the second time, or even the 5th or 6th time. We keep trying. We stick with people. And interestingly, even after folks have achieved 1 year of sustained remission, it takes another 5 years of recovery before their risk of relapse drops below 15%, which is generally considered the rate of alcohol or other drug problem, at least in the United States. Substance use disorder, probably 12%. The population-wide prevalence of alcohol and other drug use problems around 15%. And so it takes folks 5 years before their risk drops down to that of the general population. But then importantly, as I mentioned before, ultimately, people who continue trying to achieve recovery, eventually the majority of folks get there. So I just wanted to leave you with some resources if you're interested in learning more. There is a lot of hysteria around substance use and substance use disorders, so you've got to be really careful about where you get your information online. But some generally pretty good resources are NIAAA, the National Institute on Alcohol Abuse and Alcoholism, who, by the way, are working to change their name. The National Institute of Drug Abuse, who are also looking to change their name to take abuse out of the title. SAMHSA, and also I'd encourage you to check out the Recovery Research Institute, the institute I'm affiliated with. We have a great website with tons of useful information on there, including a dictionary, which has a glossary of substance use and substance use disorder related terms. And also on that website, we have a library of summarized addiction articles that we summarize as part of our monthly bulletin, which you can sign up for at recoveryanswers.org. So I'd encourage you to check that out. Thank you so much. It's been a pleasure presenting this introductory lecture on substance use disorder.